Welcome to the OMMedicine's module on febrile non-hemolytic transfusion reactions. So febrile non-hemolytic transfusion reactions are one of the more common complications of receiving a transfusion, and they're relatively benign. They don't have a lot of long-term complications, and they typically respond to supportive measures only, as we'll talk about in just a minute. And the underlying cause of this type of transfusion reaction is believed to be twofold. The first is the recipient's response to stored white blood cells, and the other is going to be the recipient's response to cytokines that have been released during the storage of blood. And the cytokine that's believed to play the largest role is IL-1. Remember, with the mnemonic hot T-bone steak, IL-1 is responsible for hot or for inducing fever, and as the name implies, with febrile non-hemolytic transfusion reaction, these patients are typically going to have a fever, which can largely be attributed to IL-1. Now, the presentation for this type of transfusion reaction is pretty straightforward. These patients are going to have fever and chills and maybe even some rigors. That's going to occur shortly after receiving the transfusion, typically within 1 to 6 hours. However, 6 hours is typically on the longer end. It's usually shortly after receiving the transfusion. So since the presentation is pretty vague and really only includes fever and chills and rigors, it shouldn't come as a surprise to you that the diagnosis is largely going to be a clinical diagnosis once all other conditions that can cause a similar presentation have been ruled out. Now, one of the major clues we can use to diagnose this type of transfusion reaction, especially in board questions, is how long it took for these symptoms to occur. And so for this type of transfusion reaction, it will occur within 6 hours of starting the transfusion or within 4 hours of stopping the transfusion. As we previously mentioned, we also need to rule out any other cause for the fever and chills and rigors, and infection is going to be one of the major causes for this type of presentation, and therefore we would need to do a full infectious workup, including blood cultures, to evaluate if the patient has an underlying infection that's actually causing these symptoms rather than a transfusion reaction. Now let's talk about the management of febrile non-hemolytic transfusion reactions, and the number one thing that you should always do and that you should remember for your boards is that the transfusion needs to be stopped. That is always going to be the first step. Now, once the transfusion has been discontinued, the treatment is largely going to be symptomatic, so you can use antipyretics to treat the fever, and then you can use other medications such as meperidine to treat some of the other symptoms such as the rigors or chills. And perhaps one of the most high yield points for you to remember about febrile non-hemolytic transfusion reactions is how to prevent them. And the major way that you can prevent this type of transfusion reaction is with leukoreduction of the transfused blood. And this means that you remove the white blood cells prior to transfusing the blood to the patient. And this is the major way that you can decrease this type of transfusion reaction. And one other high yield point to be aware of, because it is a common distractor on your board exams, is that diphenhydramine and Tylenol or acetaminophen are not going to be used prophylactically to prevent this type of transfusion reaction. The only way that you will really prevent this type of reaction is through leukoreduction of the transfused blood. And finally, I've put this summary slide here as a way to remind yourself of how the febrile non-hemolytic transfusion reaction will differ from some of the other types of transfusion reactions. So remember that part of the workup to diagnose a febrile non-hemolytic transfusion reaction is to have an infectious workup and rule out any other cause of these patients' symptoms. So if a patient was experiencing sepsis or an infection, you would expect the infectious workup to be positive, whereas in this type of transfusion reaction, it would be negative. Now, you can differentiate anaphylaxis from this type of transfusion reaction largely based on the clinical symptoms, and therefore wheezing, angioedema, hypotension, urticaria are all going to be indicative of anaphylaxis rather than this type of transfusion reaction. The best way to differentiate acute hemolytic transfusion reaction from a febrile non-hemolytic transfusion reaction is to remember that it is hemolytic or not. So in an acute hemolytic transfusion reaction, we'll have destruction of red blood cells, and therefore we will get symptoms like dark urine, we can get DIC, and then a direct Coombs test will also be positive, and all of those things will favor the acute hemolytic transfusion reaction and are typically not going to be seen in a febrile non-hemolytic transfusion reaction. And finally, you can differentiate TACO and TRALI from this type of transfusion reaction because you would expect to see cardiac and lung symptoms as well as abnormalities or changes on imaging such as a chest x-ray, both of which would be atypical for a patient with febrile non-hemolytic transfusion reactions. And that brings us to the end of this module on febrile non-hemolytic transfusion reactions.